Hello friends, today's topic is fungal infection in ICU. So, fungal infection represents a major burden in critical care setting with increasing morbidity and mortality. Candida infections, Aspergillus infection, mucormycosis are the most common ones. Each one of them requires different, although similar diagnostic and therapeutic approach. Candidiasis is the leading cause of fungal infection in intensive care unit. Candida albicans being the most common causative agent. Candida species is the part of normal human flora, and a small percentage can cause disease. Candidemia with or without endophthalmitis, disseminated hematogenous infection with a deep organ involvement, chronic disseminated candidiasis most commonly found in hematological patients. Candida bloodstream infection are the great proportion of nosocomial fungal infections and represent important cause of morbidity and mortality in ICU patients. There are several risk factors for development of invasive disease, like the colonization of gastrointestinal tract, disruption of mucosa, neutropenia, immunosuppression, the increased use of medical procedures, and poor hygiene of healthcare personnel. Now we will see the specific risk factors according to the individual Candida species. Like for Candida albicans, the risk factors are prolonged ICU stay, corticosteroid use, prolonged antimicrobial use, chemotherapy, immunosuppressive agent, diabetes mellitus, advanced age, central venous catheter, gastrointestinal surgery, total parental nutrition, pancreatitis, neutropenia, high disease severity score, that is Apache 2 more than 20, renal replacement therapy, malnutrition, multiple site colonization, major trauma, and burns over 50% of body site. Candida glabrata, elderly, malignancies, total parental nutrition, central venous catheter, solid organ transplantation, antibiotics like piperacillin, tazobactam, vancomycin, exposure to fluconazole. Then Candida parapsilosis is the second most common isolated strain in children, central venous catheter or implanted devices. Again, total parental nutrition. Then for Candida tropicalis, hematological patients, neutropenia. Candida krusei, hematological malignancy, neutropenia, recent GI surgery, use of piperacillin, tazobactam, vancomycin in prior exposure to fluconazole. Then Candida guillermondi, any intravascular catheter is the risk. Then we'll see the Candida colonization index. It is defined as ratio of the number of culture positive surveillance site for Candida species over number of site culture. Now, if this Candida colonization index is greater than 0.4, then we can start preemptive antifungal therapy. Now, we'll see what is Candida score. Now, Candida score is totally based on the risk factors. Like if there is a surgery upon admission, then 1 score. If the patient is on total parenteral nutrition, then 1 score. If the patient is in severe sepsis, then 2 score. Multifocal colonization, 1 score. And if this Candida score is above 2.5, then that identifies high risk patient who might benefit from antifungal prophylaxis treatment. Now we'll see what are the lab diagnoses which are required for diagnosis of fungal infection. The first one is blood culture. It has a sensitivity of up to 70%, but they have long incubation time and they are often negative in deep seated candidiasis and when fluconazole prophylaxis is used. Now the next is serological test, which uses the component of fungal cell wall like galactomannan, 1,3-BDG, or antibodies against galactomannan antigen are specific, but they lack sensitivity. Then the next test is real-time polymerase chain reaction. It has sensitivity of 60% in diagnosing candidemia, and it is invaluable in diagnosing deep-seated candidiasis with negative blood culture. Newer diagnostic tests were introduced, such as matrix-assisted laser desorption ionization time or flight mass spectroscopy. It should be noted that Malditov currently is the most promising method for rapid identification once fungal organism has been isolated. Molecular detection of fungi in blood and the fluorescence in situ hybridization, promising an accurate and faster diagnosis. Now, uh, now we'll see what are the empirical and preemptive treatment. Antifungal prophylaxis may be useful when there are risk factors or increased local incidence rate. Patient may benefit from the antifungal prophylactic treatment with fluconazole against invasive candidiasis are those who recently underwent abdominal surgery, recurrent gastrointestinal perforations, and anastomotic leak. In patients with multifocal candida colonization who have clinical risk factors for infection, but if they are in stable condition, then preemptive therapy is currently not indicated. In patients with refractory fever receiving broad spectrum antibacterial therapy, empirical antifungal therapy may be administered and thorough search for alternative causes should be performed. Documented candidiasis. Antifungal drugs for the treatment of candidiasis include pollines like amphotericin B deoxycholate, liposomal amphotericin B, then triazoles like fluconazole, itraconazole, voriconazole, and posaconazole. Then the next class is echinocandins, which include capsofungin, anidulafungin, micafungin, and flucytosine, administered mostly by oral formulation. However, it is also available as intravenous formulation. Amphotericin B deoxycholate. It is a fungicidal properties by interacting with membrane sterol, increasing the permeability of the cell membrane, and it allows leakage of fungal cell component resulting into cell death. It demonstrates high minimum inhibitory concentrations for Candida glabrata, Candida krusei, and it has got narrow therapeutic window. Its lipid formulation retains the activity of the parent drug, exhibits better safety profile, but they are more costly. Main adverse effects include nephrotoxicity, hepatotoxicity, anemia, and thrombocytopenia. Nephrotoxicity and acute infusion-related reactions are most prominent and most frequent adverse events. So the recommended dosages are 0.1, 0.5 to 1 mg per kg for amphotericin B and 3 to 5 mg per kg daily for its liposomal formulations. All triazoles are fungistatic and they inhibit cytochrome P450 enzymes. Fluconazole has the greatest penetration into CSF and vitreous body. Voriconazole is not recommended in patients with the clearance lower than 50 ml per minute or under hemodialysis due to possible accumulation of cyclodextrin. Posaconazole is not available in intravenous formulation and can be used in neutropenic patients with the leukemia. They interact with the several drugs, increasing their concentrations like cyclosporine, warfarin, tacrolimus, and carbamazepine. They also increase the serum level of fentanyl and midazolam through competitive inhibition. The recommended intravenous dosages are two loading dose of 6 mg per kg every 12 hours, followed by 3 to 4 mg per kg every 12 hours for voriconazole. Then dose adjustment in the renal failure should be done. Itraconazole, posaconazole, although active against Candida, they have no label against the invasive candidiasis. Now the echinocandidates like caspofungin, micafungin, anadulafungin inhibit synthesis of beta-3, 1,3 beta glucan, and they are fungicidal against Candida species. The active drug is not excreted in the urine. Thus, they are not used in patients with candidiuria, and it represents the high minimum inhibitory concentration for Candida parapsilosis. They possess favorable therapeutic profile with few drug interaction and minor toxicity. The recommended dosing regimens are loading dose of 70 mg followed by 50 mg daily for caspofungin, loading dose of 200 mg followed by 100 mg daily for anadrolafungin, and 100 mg daily for micafungin. It should be noted that caspofungin should not be used for prophylaxis against invasive candidiasis. Now, the candida infection in the ICU may be suspected or documented, usually by obtaining positive blood culture. Now, what is the suspected candidiasis? If the patient has a risk factor for candida infection, then the prophylaxis treatment may be initiated, usually with fluconazole. Risk factor in combination with the positive serological marker may indicate patient eligible for preemptive treatment. Now, what is documented candidiasis? Documented candidiasis is the one when blood culture showed the growth of yeast without waiting for species identification and the result of susceptibility testing. In the presence of candida infection, conservative blood culture should be obtained. The length of treatment is identified like 14 days after the last positive culture. And once the after the isolation of this candida species, it is recommended that central venous catheter, implanted devices like pacemaker, implanted defibrillators should be removed. Fundoscopic examination should be done in order to exclude endocular infection. Now, what is the treatment for localized infection? If it is a pyelonephritis, then the primary therapy is fluconazole 200 to 400 mg for 14 days, and the alternative therapy is amphotericin B deoxycholate 0.5 to 0.7 mg per kg daily, plus minus flucytosine 25 mg per kg 4 times daily, or flucytosine alone for 40 days. Then there is osteomyelitis, then we can start with fluconazole, 400 mg daily for 6 to 12 months. Lipid formulation of amphotericin B, 3 to 5 mg per kg daily for several weeks. Then fluconazole for 6 to 12 months. Alternative therapy is echinocandin or amphotericin B deoxycholate, 0.5 to 1 mg per kg daily for several weeks. Then fluconazole for 6 to 12 months. If there is a septic arthritis, then the primary therapy is fluconazole 400 mg daily for at least 6 weeks. Lipid formulation of amphotericin B 3 to 5 mg per kg daily for several weeks, then followed by fluconazole. And the alternative therapy is echinocandin or amphotericin B deoxycholate 0.5 to 1 mg per kg daily for several weeks, and then fluconazole. CNS candidiasis, we can treat it with lipid formulation of amphotericin B 3 to 5 mg per kg plus flucytosine 25 mg per kg 4 times daily for several weeks, followed by fluconazole 400 to 800 mg daily until resolution of symptom. Or alternative therapy consists of fluconazole 400 to 800 mg daily for patient intolerant to the lipid formulation of amphotericin B. If it is endophthalmitis, again we can treat it with amphotericin B deoxycholate with slightly reduced dose, that is zero point 0.7 to 1 mg per kg, with flucytosine, that is 25 mg per kg 4 times daily for at least 4 to 6 weeks, along with the surgical intervention for severe cases. Alternative therapy is lipid formulation of amphotericin B with a dose of 3 to 5 mg per kg daily. Voriconazole 6 mg per kg twice daily for 2 doses, then 3 to 4 mg per kg twice daily. Cyanocandins also we can use. Uh, if there is an endocarditis, then lipid formulation of amphotericin B 3 to 5 mg per kg plus flucytosine 25 mg per kg 4 times daily. Amphotericin B deoxycholate 0.6 to 1 mg per kg plus flucytosine 25 mg per kg 4 times daily. And we can also use echinocandins. Alternative therapies, valve replacement is strongly recommended. Otherwise, chronic suppression with the fluconazole, that is 400 to 800 mg daily, is recommended. Lifelong suppressive therapy for prosthetic valve endocarditis, if valve cannot be replaced, is recommended. Now the treatment of documented invasive candidiasis. So according to ESC MID guidelines, which are published into 2012, we can start first line therapy is anidula fungin, 200 mg loading dose, then 100 mg per day. Then other drug is caspofungin that we can use like 70 mg loading dose, then 50 mg per day. And we can also use micafungin. Now, alternative doses liposomal amphotericin B 3 mg per kg or voriconazole we can give 3 to 6 mg per kg per day. Fluconazole we can give 400 to 800 mg. Amphotericin B lipid complex with a dose of 5 mg per kg. Now, according to IDSA guideline, which are published in 2009, if the patient is stable, then we can start with fluconazole, that is 800 mg loading dose, then 400 mg. If patient is unstable and recent use of fluconazole, then anidula fungin 200 mg loading dose, then 100 mg per kg day. And we can give caspofungin, that is 70 mg loading dose, then 50 mg per day. Or we can use micafungin, that is 100 mg per day. And alternative therapy is for a stable patient, lipid formulation of amphotericin B 3 to 5 mg per kg daily and amphotericin B deoxycholate 0.5 to 1 mg per kg daily. And if patient is unstable, we can use voriconazole 400 mg twice daily for 2 doses, then 200 mg twice daily. Now the next infection is aspergillosis. Aspergillus is the fungal genus encompassing 100 of molds. The most clinically important of which are Aspergillus fumigatus, Aspergillus flavus, Aspergillus terreus, Aspergillus niger, and Aspergillus nidulans. It has a wide environmental distribution, or it may be found in soil, water, air, and decomposing organic matter. It may colonize and may infect and cause infection mostly in the immunocompromised patient. Epidemiology, incidence, and outcome. In critical care setting, Aspergillus may harbor the ICU ventilation and water system that have been poorly maintained as well as in the various equipment. However, there is a difficulty in discriminating between the colonization and infection when they are isolated from the patient. Incidences varies depending upon the immune status of the patient. Any organ may be affected by Aspergillus species, with the sinopulmonary involvement as invasive aspergillosis being the most common. So the lowest incidence for invasive aspergillosis is reported in the patient with HIV and in patient with hematological malignancy, which is 0.4%. The incidence of patient with the solid organ transplant may vary from 0.5 to 2.4%, while in patient with stem cell transplant vary from the 0.5 to 3.8%. In patients with the hematopoietic stem cell transplantation, incidence rate are about 5% for autologous and 5 to 10% for allogeneic transplantation respectively. Mortality rates also varies. The overall mortality rate for aspergillosis are about 17% based on US national data. Mortality is higher in case of Aspergillus pneumonia and in immunocompromised patients with invasive aspergillosis. Specifically in Aspergillus pneumonia, mortality rise to 25%. In patients with the blood and the lymphoid tissue malignancy, bone marrow transplant recipient, liver transplant recipient, mortality rate of invasive aspergillosis is 49%, 80%, and 90%. It should be noted that immune status of the critically ill patient as well as other underlying condition are most important determinant of the type of fungal infection they may have, and it is usually of invasive form. Patients receiving steroids are increased risk for having cavitary region and aspergillosis. Neutropenic patients develop angioinvasive aspergillosis as neutrophils plays a major role in the clearance of aspergillus. Patients who receive lung transplantation are often colonized with the aspergillus due to their primary lung disease and more likely to present with aspergillosis around the anastomosis. Also, the involvement of other foci, including endocarditis, osteomyelitis, have been reported. Now, the risk factor. Neutropenia was the first risk factor to be recognized for invasive aspergillosis more than 40 years ago. The absolute neutrophil count number per se is not sole determinant, as overall neutrophil functional status plays important role in the pathogenesis of aspergillus. However, one should keep in mind that neutropenia and compromised immune functional status usually concur in several conditions. Common neutropenic conditions that may lead the development of invasive aspergillosis are hematological malignancy, myeloablative chemotherapy, and stem cell recipient. Prolonged duration and degree of neutropenia are important factor of developing the disease. Solid organ transplantation recipient, especially of lung, are at increased risk for invasive aspergillosis as they receive immunosuppressive therapy and are subjected to environmental exposure to aspergillus. Regarding the deterioration of the immune system functionally, uh, steroid therapy is the major risk factor as it may administered either as anti-inflammatory drug in the course of infection, as immunosuppressant treatment during transplantation. Other similar conditions associated with invasive aspergillosis are prior antibiotic treatment, AIDS, H1N1 infection, chronic obstructive pulmonary disease, chronic granulomatous disease, acute renal failure, patient receiving immunomodulatory drug, namely TNF-alpha inhibitor, and also are at increased risk for invasive aspergillosis. The diagnosis is based on the triplet consisting of the risk and host factor, then clinical and radiological signs and symptoms that are indicative of the disease, and laboratory testing that proves the existence of aspergillus, either directly or indirectly. So, according to the definition published by European Organization for Research and Treatment of Cancer Mycosis Study Group, the utilization of these criteria classify the diagnosis of invasive aspergillosis in proven, probable, and possible. So, what is proven infection? So, for proven infection, it is required to have positive culture of otherwise sterile site or positive histopathological or cytopathological examination. It should be noted that although very useful in the diagnostic process, clinical symptoms, signs, risk, and host factor are not mandatory when the presence of aspergillosis has been demonstrated. For probable infection, all elements of aforementioned triplet are required to be positive. And for possible infection, diagnosis can be done when there are appropriate risk factors and host factors, and clinical symptoms and signs. But mycological evidence is lacking. The radiological tests that may be used are chest X-ray, CT scan. The most common signs that may be found are consolidation and infiltrate and nodule. However, the pathognomic sign is halo sign, which is found in the CT scan as nodule with a dense center surrounded by ground glass opacity. It should be noted that the latter is the most commonly found in the neutropenic patient, while the relevant finding of non-neutropenic patients are non-specific. Laboratory testing used for detection of aspergillus include biopsies, culture, detection of galactomannan, BTG, and PCR. The isolation of aspergillus from the culture depend upon whether the site of isolation is otherwise sterile. Since positive culture from respiratory tract secretion, irrespective of method used for isolation, may represent colonization rather than infection. Galactomannan is detected in the body fluids, and depending on its concentration, galactomannan index is calculated. Although the sensitivity of the method in the serum is limited, it seems that galactomannan detection in the bronchoscopic material, such as bronchoalveolar lavage, has a superior accuracy and is not affected by the immune status of the patient. BDG is like galactomannan, cell wall component, which is also found in the body fluids and its presence indicates the probability of the infection. PCR, although it is a method with high sensitivity and specificity, it is cumbersome and lack in distinction power between colonization and infection. So the quantitative real-time PCR may pose an useful alternative in the diagnosis of invasive aspergillosis. So the treatment of aspergillosis may be classified as empirical treatment, preemptive treatment, and definitive treatment. So empirical treatment is the one administered to neutropenic patients who are at high risk of prolonged febrile period and who have already received broad antibiotic coverage. Preemptive treatment is the one administered when there is a evidence of fungal existence without development of infection. And definitive treatment is one administered when infection has developed and it is based on antibiogram data. When definitive treatment with single agent is not successful, then we should go for the combination of the treatment. Prophylactic treatment, although administered in the neutropenic patient, has not found its place in the critical care setting. Adjunctive therapies, including granulocyte colony stimulating factor, interferon gamma, may also be used. Surgical treatment for resection of aspergillus lesion may be alternative option in selected cases. Amphotericin B, azole, and echinocandins may be useful for treatment of aspergillosis. Voriconazole is considered as first-line treatment, especially in invasive pulmonary form. It is administered as intravenous form in the dose of 6 mg per kg twice daily as a loading dose. Then dose is lowered to 4 mg per kg twice daily. Amphotericin B is administered intravenously as a liposomal amphotericin in the dosage of 3 to 5 mg per kg per day, or its lipid complex in the dosage of 5 mg per kg per day. But it has lost its predominance due to nephrotoxicity. From echinocandin class, only caspofungin has been approved for the treatment of aspergillosis, but is used when treatment with the other agent is not successful and not allowed due to adverse events. It is used mostly when other antifungal have failed, and it is administered in the combination with the amphotericin. It is administered intravenously in the dosage of 70 mg per kg as a loading dose and 50 mg per day thereafter. When administered in combination with the calcineurin pathway inhibitor, it has found to have increased in vitro activity. Itraconazole, posaconazole is considered second-line treatment option. Posaconazole has been approved as a salvage treatment of invasive aspergillosis. The duration of treatment varies depending upon the patient immunity status. In non-immunosuppressed patient should last for a minimum of 6 to 12 weeks. In immunosuppressed patient, treatment should be administered as long as patient is immunosuppressed and should not be stopped until clinical and radiological resolution of symptoms and signs. Relapse due to incomplete eradication and lack of sterilization of underlying foci may occur. Now, the last infection is mucormycosis. Mucorales are saprophytes causing disease known as mucormycosis. The most common genera include Rhizopus, Mucor, and Rhizomucor. The risk factor in the critical care setting include neutropenia, diabetes, malignancy, desferoxime therapy, renal failure, hematopoietic stem cell transplantation, and penetrating trauma. Mortality is high, ranging from 35% when no underlying condition is present to 66% in patients with the malignancy. Methods for diagnosis of mucormycosis are limited. The sole approach that may provide evidence of mucorales presence is through histopathology, using hematoxylin leucine, Grocott, methenamine silver, and a periodic acid skip stain. PCR use has been described, but it is not routinely used. Radiological testing rarely provides specific findings. Treatment options are also limited. The mainstay treatment is amphotericin B, the deoxycholate, lipid complex, and liposomal form. The dosage is 1 to 1.5 mg per kg per day and 5 to 7.5 mg per kg per day and 5 to 10 mg per kg per day. The deoxycholate form, the most toxic and with poorest penetration into central nervous system, is the only formulation approved for the treatment of mucormycosis. Limited data regarding combination treatment of lipid amphotericin with echinocandin are also. The combination of deferoxerox with the lipid amphotericin was found to be highly fungicidal in animal models. Mucormycosis treated with deferoxerox had high mortality rate at 90 days and did not support the role for initial and adjunctive deferoxerox therapy for mucormycosis. The surgical debridement may be used as an adjunctive therapy. The duration of treatment for mucormycosis is not established and should be individualized for each patient. It should be continued until there is resolution of clinical signs and symptom, radiological finding, if any, and of immunosuppression. So, thank you.